Hello, welcome to this presentation about the radar, and this one is devoted to the result highlights. My name is Philippe Boyer and I was the lead researcher on this project. I'd like to remind you that everything that's going to be presented in this presentation, you can find all the details in the article that was published in BMC Nursing, and as also you can see all the others that participated in this project. Before I present the results, I'd like to talk a little bit about delirium. So what is delirium? The first definition that comes to mind about delirium is to talk about the DSM-5. The DSM-5 in fact presents the criteria for what is a delirium. So the criteria 1 is disturbance of attention, a level of consciousness. Criteria B, it's a disturbance that develops over a short period of time and tends to fluctuate during the course of the day. But I'd like to point out that in the DSM-5, the fluctuation nature and the acute onset has to be related to inattention and altered level of consciousness. So this is something new. And in criteria C, it's additional cognitive problems. It can be memory impairment, disorientation, hallucination. There are also other criteria related. These are the exclusion criteria, but I won't go over them right now. There is also the definition of definite delirium, which is based on the CAM, a well-known tool that is used throughout the world. So to have a definite delirium, a patient needs to meet criteria feature 1, if you prefer, feature 2, and either feature 3 or feature 4. And so feature 1 is an acute onset and fluctuation course. Feature 2 is inattention. Feature 3 is disorganized thinking. And feature 4 is altered level of consciousness. Something important to mention, the acute onset and fluctuating course can be anything related to cognitive impairment, behavioral disturbances, or even a change in the sleeping habit patterns of the patient. So it's very different than the first criteria of the second criteria of the DSM-5. There is also another definition of delirium. This one is called probable delirium, based also on the CAM. The CAM, we use the same features 1, 2, 3, and 4, but the feature 1 has a tiny change that is clinically important though. It's acute onset or fluctuating course instead of acute onset and fluctuating course. So for having a probable delirium, you just have to meet also feature 1 and 2 and either 3 and 4, but the feature 1 is only acute onset or fluctuating course. There's also a new concept out there that attracts more and more attention by the researchers and even clinicians now. It's the definition of subsyndromal delirium. Subsyndromal delirium, according to Cole's criteria, a patient have to meet 2 of the following symptoms: altered level of consciousness, inattention, disorientation, and hallucination. So why do we see more attention devoted to what we call SSD for subsyndromal delirium? It's because there are negative outcomes associated with having this subsyndromal delirium syndrome as well. Here is not a definition of delirium, but it's something that is also very important for a clinician to know, and also it will help to interpret the results about the radar. It's the fact that having one symptom of delirium, and the symptoms that we are looking at are a fluctuation of symptoms or inattention or disorganized thinking or altered level of consciousness. If you have one of these symptoms but you don't meet criteria for DSM-5 delirium or CAM probable or definite delirium or SSD, but you still have one symptom of delirium, so we know now that it has a clinical meaning. It's very important to pay attention to this symptom because it increases the risk that you develop delirium. And also having one symptom, we know that it causes negative outcomes such as functional impairment, cognitive impairment, depressive mode, and behavioral problems. So if I sum up, If you have DSM-5, there's certainly negative consequences, but even when you meet other criteria, a set of criteria such as the definite or probable delirium or SSD, or even if you have only one symptom, it is clinically important to detect them because there are negative outcomes associated with them. So what I've just said explain why clinicians and researchers now have suggested to include the measure of the 6 vital signs. We know the classic vital signs: blood pressure, heart rate, respiratory rate, temperature. The 5th vital sign as well, now the pain. But now we really recommend to measure mental health because of just what I said related to the negative outcomes. So the definition of the 6th vital sign would be an altered level of consciousness and inattention. To conclude on all these concepts that I just described, the 6 vital sign, the SSD, and all the definitions about delirium, this graph kind of present everything in only one slide. You can see on the left the negative outcomes and also the probable trajectory. If you have one core symptom of delirium, you're more likely to develop SSD or the 6 vital sign, and then a CAM definite or probable, and finally a DSM-5 delirium. So, but also what it shows, it's the negative outcome. You already have negative outcome if you have one core symptom, but the negative outcome are more important if you have SSD or a 6 vital sign and so forth. I think we are ready now to look at the results, but just before we do that, a quick reminder about what is the radar. So here you have the radar. I suggest that if you want to have more details about the radar and how to administer it, you can see the video. There's a video training about it. But very quickly, there's only 3 items in the radar. So we ask the question, when you gave the patient his or her medication, was the patient drowsy? Did the patient have trouble following instructions? And were the patient's movements slowed down? You just have to check yes or no, and you complete it after you have given the medication. So you do it in the morning, in lunch, dinner, and before the patient goes to bed. Now we turn to the results. I'll begin by showing you the results, the descriptive ones. First of all, there were 193 resident and patient in this study. It was conducted in acute care hospital in a nursing home. 541 radar were administered to them. Among these, 18% were we had radar positive. To have a radar positive, there needs to be only 1 item score positive among the 3 during the day. So the most of the time there was only 1 item that was scored positive. In fact, 58% of the time, and the administration time was on average 7 seconds. One important thing that you do when you do a validation study is you test for inter-rater reliability. And usually how we do it in research, we compare 2 research staff doing the assessment. In this study, we were very interested in comparing nursing staff doing all their tasks that they have to do in real-life situations with the research staff that devoted all their attention to complete the radar. So we did inter-rater assessment 52% of the time. So we did it many times. And as you can see, the percentage of agreement is satisfactory to a very high percentage of agreement. So from 82% to 98%. We look as well at the concurrent validity of the radar compared to a DSM-5 criterion-defined delirium. And as you can see, the sensitivity was 65%, specificity was 71%, and positive predictive value 22%, and negative predictive value was 94%. One important aspect of the radar is that you complete it many times during the day, so in the morning and lunch and so forth. So we wanted to look at if a patient had 3 or 4 radar administered, does the radar perform better in regard to its sensitivity? So in our study, we had 113 participants that had 3 or 4 radar administered during the day, and as you can see, the sensitivity increased to 73%. We wanted to look also at the positive predictive value because we were a bit concerned about the 19% positive predictive value, and as you can see at the bottom, we had in fact 34 participants that had a positive radar but no DSM-5 delirium. But when we did the breakdown of if they were meeting any other set of criteria, we could see that in fact 100% of them, they had cognitive impairment. They were meeting criteria for CAM definite delirium or CAM probable or SSD. So in other words, they all have something going on. Another aspect very important when you study a tool with that wants to detect delirium is how it performs in subsamples of participants. Because, for instance, we know that many tools are not validated with patients with dementia or cognitive impairments, or that we know that some tools, they don't perform as well to detect hypoactive delirium, for instance. So we wanted to look at these subsamples. So you can see here that the sensitivity of the radar is still the same when we look at patients with cognitive impairment or without cognitive impairment, with psychomotor retardation. So this one is very important because, as I mentioned, we know that for this one, the level of detection is very low. A patient in hospital, it doesn't change the sensitivity. In fact, we see an improvement with resident in nursing home, but there were only 40 participants in this subsample. So we have to be careful for this one in the interpretation of the sensitivity. As a clinician, I was also very interested in looking at the acceptability of the tool, because I know for a fact that if you don't have the acceptability of a tool from the nursing staff, they won't use it. So that's why we did interviews with them at the end of the study, and we asked them if they agree or disagree with different statements. So as you can see, 100% of the participant of the nursing staff, they said that the radar items are easy to understand, and also that observing the patient during the distribution of medication is a good time to do the radar, and also that they have sufficient knowledge. 99% of them said they have sufficient knowledge to use the radar. And one important thing, it's the last one, and it's completing the radar does not result in an important increase of my workload. 99% of them agree with that statement, which is very important because usually this is one obstacle that is well known about not using a tool if it takes too much time. Some researchers or clinicians may have concern about the sensitivity of the radar. They may say, well, 73%, it's not 95%, it's not 90%. So is the sensitivity of the radar is high enough? Well, it depends with which study you're comparing your results. If you're looking at, you want to compare the radar with other tools that are used by research staff that devote all their time to doing an assessment, well, you will see that in these studies the sensitivity is very high, 95%. But when you look at studies that have tested the validity of a tool, but when it's used by bedside nurses doing their regular activities, well, we see that the performance of a tool decreases because it's more difficult to achieve high level of sensitivity in these contexts. So in this study, they tested the CAM ICU, and the ratio was only 1 patient per nurse. So they still have, a very small ratio, but the sensitivity was 27%. And some nurses, they find it was difficult to use the tool, so that's why they wouldn't use it on a long term. There are also another study that looked at exactly the same thing in intensive care unit, and when the bedside nurses, they were using the CAM ICU, the sensitivity was 47%. But still, if you look at studies that have looked at the validity of the CAM ICU when it's done by research staff, we know that the CAM ICU is a very good tool that reach very high sensitivity and specificity. But when it's used in reality, we are not able to replicate these high sensitivities. In this study, what they did is to test the implementation of the CAM, a tool that no one is questioning its validity. In research, we use the CAM and we know that we can reach 95–98% sensitivity. But in this study with nurses, bedside nurses, working with all their different tasks, well, they reach a detection rate of 10–25%. In fact, something we've learned for the past, studying the delirium for the past 10 years or 15 years, is the fact that detecting delirium, it's possible. We are able to detect all cases of delirium if you want, but everything is a matter of time. In this graph, you can see that everything is a matter of time. If you spend 50 minutes per patient, so you do 3 interviews with the CAM and 1 HDS, which is a cognitive test, then you have a sensitivity of 100%. If we remove the data from one CAM, so we have to remove also 10 minutes from the time required to do the assessment, well, the sensitivity decreases as well to 91%. If you do 1 interview with the CAM and 1 HDS, so now you spend 30 minutes with the patient, then your sensitivity is now at 78%. So we can see that there's clearly a relation between the time you spend with the patient and your capacity to detect if the patient has delirium or not. So when you look at the radar, we have to spend 30 seconds if you do 4 radar in 1 day, then you have a sensitivity of 73%. So when you take into account the time invested and the sensitivity that you get, we can say that the radar is 73 times more efficient than the gold standard, which is doing 3 CAM assessment with 1 HDS. We wanted also to look at the concurrent validity of the radar with respect to a positive 6 vital sign. A positive 6 vital sign is when a patient meets criteria for inattention and an altered level of consciousness. And so you can see in the table that the sensitivity is 70%, specificity is 83%, and the positive predictive value is 71%. And also we did a breakdown to look at the 12 participants that had a positive radar but a negative 6 vital sign. In fact, 8 demonstrated inattention and 3 an altered level of consciousness, but they didn't have both. So in fact, 92% of them had one sign present of the 6 vital signs. To conclude this presentation, I'd like to come back to a poster that we created right from the start of this project, because the goal was really to do a radar and then do a CAM and then collaborate with the physician so we can make a diagnosis of if there is a delirium or not. But based on our results, what we can say is that if there's a positive radar, you are well advised to skip the second step and contact the physician, because most of the time the patient or the resident has something going on in his mental health that deserve attention. But if you're not sure, what you can do, if there's a positive radar but at the same time the patient or the resident has comorbidities and you're not sure, so what you can do is to do a CAM. Then you have a positive radar, then you do a CAM, and depending on the results of your assessment with the CAM, then you can contact the physician or not. But I remind you that most of the time you can go directly from the radar to the physician. Before I finish this video, what to keep in mind? Is radar a screening or a detection tool? I would say that given its performance, it performs in fact like a detection tool, so you can use it as such. But still, a tool should never take a decision for you. So clinical judgment is of paramount importance. So what is the future for the radar? Well, we have many other studies right now underway, and we are validating it in different subpopulations and also in different clinical settings. We just finished to validate the radar in the emergency room, but we also have studied in palliative care, at home as well, and when it's administered by a nurse or a family member. So if you want to be informed about the radar, you can visit the website. And also, I was delighted to see that the radar was validated in the States, for instance, by a PhD student. So really, I invite you to come on board if you want to validate the radar in your own country and in your setting. You are really more than welcome to do so. So thank you very much for your attention.